Here is additional rhythm review practice from class. The rate is 100 to 110. The PR interval is 0.16. The QRS is 0.08. The interpretation is sinus tachycardia. The next course of action is to check the patient if new onset, or if the patient is symptomatic, then notify the physician. The rate is 80. PR interval is 0.2. QRS is 0.08. The interpretation is sinus rhythm with a burst of paroxysmal supraventricular tachycardia. The next course of action is to check the patient, obtain vital signs, and notify the physician. The rate is 70. The PR interval is unable to determine. The QRS is 0.08. The interpretation is atrial fibrillation. The next course of action is to check the patient. If new onset or patient is symptomatic, then notify the physician. People who have atrial fibrillation are at increased risk for stroke, and this is because the blood can pool in the heart's upper chambers, causing a clot to form, and if that clot breaks off and travels to the brain, it can cause a stroke. This is why they are prescribed blood-thinning medications like warfarin, dabigatran, heparin, aspirin. It's important to do rate control, and this is a recommended treatment for most patients who have atrial fibrillation, even though an abnormal heart rhythm continues and the heart doesn't work as well as it should. Most people feel better and can function well if their heart rates are well controlled. Medications used to control the heart rate include beta blockers like metoprolol or atenolol, calcium channel blockers like diltiazem and verapamil, and digitalis, digoxin. A procedure could include Electro Cardioversion and is used to treat a fast or irregular heartbeat. Low energy shocks are given to the heart to trigger a normal rhythm. The patient is sedated before receiving these shocks. For atrial fibrillation, the cardioversion is usually a planned procedure. A transesophageal echocardiography, a TEE, could be ordered to rule out the presence of blood clots in the atria. If the clots are present, they would need to take blood-thinning medications before the procedure. A catheter ablation may be used to restore a normal heart rhythm if the medications or the electrical cardioversion do not work. A radio wave energy is sent through a wire to destroy the abnormal tissue that may be disrupting the normal flow of electrical signals. Sometimes the catheter ablation is used to destroy the atrioventricular node, and that's where the heart's electrical signals pass from the atria to the ventricles. This procedure would require a pacemaker, which would help maintain a normal heart rhythm. Medications then to control the heart rhythm would be amiodarone, sotalol, flecainide, propafenone, dofetilide, and ibutilide. Sometimes older medications like quinidine, procainamide, and disopyramide are used. The rate here is 190. Unable to determine the PR interval, and the QRS is 0.08. This is supraventricular tachycardia. The next course of action is to check the patient and obtain vital signs and notify the physician. The rate here is 80. The PR interval is 0.2. The QRS is 0.06, and the interpretation is sinus rhythm with a pause. Next course of action, check the patient, obtain vital signs, and notify the physician. The rate is 70. The PR interval is 0.2. The QRS is 0.1. This is sinus rhythm with peak T waves. The next course of action is to check the patient, vital signs, and check the potassium. The rate is 70. The PR interval is 0.16, and the QRS is 0.08. This is sinus rhythm with frequent premature atrial complexes. The next course of action, check the patient. If they're symptomatic, call the physician. The rate is 110. The PR interval is unable to be determined. The QRS is 0.08. This is junctional tachycardia. Check the patient, get their vital signs, and notify the physician. The rate is 50. The PR interval is 0.32. The QRS is 0.08. This is sinus brady with first-degree AV block. The next course of action is check the patient, the vital signs. If new onset or symptomatic, notify the physician. The rate is 30. The PR interval is unable to be determined. The QRS is 0.16. The interpretation is third-degree heart block. The next course of action is to check the patient, get vital signs, notify the physician immediately, and prepare to pace the patient. The rate is 50, the PR interval is variable, the QRS is 0.08. The interpretation is second degree AV block type 1, Winky Bach. The next course of action is to check the patient, obtain vital signs, and notify the physician. The rate is 40, the PR interval is 0.16, the QRS is 0.06. This is second degree AV block type 2, a Mobitz 2. Check the patient, obtain vital signs, notify the physician immediately, and prepare to pace the patient. The rate is 90, the PR interval is 0.16, the QRS is 0.08. This is Sinus Rhythm with Pvc Couplets. Check the patient, obtain vital signs, and notify physician if the couplets persist. The rate is 70, unable to determine the PR interval. The QRS is greater than 0.16. This is 100% ventricular paced. Continue to monitor the patient. The rate is 70, the PR interval is 0.2, the QRS is 0.06. The interpretation is sinus rhythm with 6 beats of ventricular tachycardia. The next course of action is to check the patient, obtain vital signs, and notify the physician. The rate is 40, the PR interval is none, QRS is 0.4. This is an idioventricular rhythm. The next course of action is to check the patient, obtain vital signs, and notify the physician immediately. If the patient is pulseless, then call a code. The rate is 40, the PR interval is 0.2, the QRS is 0.08. This is sinus bradycardia, and continue to monitor the patient. If the patient is experiencing symptomatic bradycardia, then atropine can be used to increase the heart rate and conduction through the AV node. Also, treatment with a transcutaneous pacer could be appropriate. Now, because atropine increases electrical conduction, it does not increase cardiac contractility, so the quality of the peripheral pulses would not be used to evaluate the drug's effectiveness. The rate is none, the PR interval is none, the QRS is none. This is ventricular fibrillation. Call code blue, obtain an AED, and prepare to shock the patient. Rate is none, PR interval is none, QRS is none. This is asystole. Call code blue and begin CPR. The initial intervention is to start CPR, administer oxygen if hypoxemic, attach a monitor and defibrillator, monitor blood pressure and oximetry, and identify and treat reversible causes. Then check the rhythm. If it's a shockable rhythm, then it would be VFib and VTAC. If it is not a shockable rhythm, then it would be asystole and pulseless electrical activity. The initial treatment for asystole, or PEA, is to continue CPR for 2 minutes. Obtain intravenous or interosseous access. Administer vasopressor like epinephrine every 3 to 5 minutes. Check the pulse and rhythm every 2 minutes. If not shockable, then go back to continuing CPR. If it is shockable, then follow ventricular tachycardia and ventricular fibrillation algorithm. A rate of 70, unable to determine the PR interval, and the QRS is 0.06. This is atrial flutter. Check the patient if it's a new onset or a patient is symptomatic, then notify the physician. Atrial flutter is usually regular and has a narrow QRS configuration and has flutter waves representing atrial activity. Radiofrequency catheter ablation therapy uses electrical energy to burn or ablate areas of the conduction system as a definitive treatment for atrial flutter and tachydysrhythmias. With atrial flutter, the goal is to restore normal sinus rhythm. Atrial flutter will usually present with atrial rates between 240 and 350 beats per minute. These rapid atrial rates are caused by electrical activity that move in a self-perpetuating loop within the atria. The impact and symptoms of atrial flutter depend upon the ventricular rate of the patient, the cardiac output. Usually with atrial flutter, not all of the atrial impulses will be conducted to the ventricles, and the more atrial impulses that are conducted, the greater the negative effect. Symptoms of atrial flutter are similar to those of atrial fibrillation and may include palpitations, chest pain, discomfort, dyspnea, dizziness, nausea, nervousness, and feelings of impending doom. Symptoms of heart failure such as activity intolerance and swelling of the legs can occur with a prolonged fast flutter. The complications of atrial flutter share the same complications as atrial fibrillation. These complications are usually due to ineffective atrial contractions and rapid ventricular rates. Ineffective atrial contractions can lead to thrombus formation in the atria and rapid ventricular rates and can cause decompensation and heart failure. To prevent complications from atrial flutter usually begins with early cardioversion. Treatment for atrial flutter is the same as atrial fibrillation. When atrial flutter produces hemodynamic instability and serious signs and symptoms, it is treated with ACLS protocol. For the patient with unstable tachycardia due to a tachyarrhythmia and atrial flutter, immediate cardioversion is recommended. Cardioversion. Atrial flutter is considered more sensitive to electrical direct current cardioversion than atrial fibrillation and usually requires a lower energy shock. 20 to 50 joules is commonly enough to revert to sinus rhythm. The American Heart Association recommends an initial shock of 50 to 100 joules for cardioverting an unstable atrial flutter.